Hi, everyone. I'm Eddie,
And I'm Raj.
and this is Blood Cancer Talks. We're a podcast dedicated to hematologic malignancies where we bring content experts who live and breathe a particular disease and focus on the latest advances in biology and clinical management. Please take a moment to rate and review our podcast in whichever app you listen to your podcasts in. Today, we're excited to review the hottest updates in lymphoma from the American Society of Hematology, or ASH 2023 meeting held just a week ago in San Diego. We're delighted to be joined by Dr. Toby Eyre, who was so great on last year's ASH recap episode that we've invited him back to join us again this year. Dr. Eyre is a consultant hematologist at the University of Oxford in the UK who specialises in the management of CLL and lymphoma. Toby completed his doctorate on the topic of early phase clinical trials and biomarker studies in lymphoid malignancies and serves on the low-grade and elderly high-grade lymphoma groups of the UK's NCRI. Thank you so much for joining us again for our ASH Highlights episode, Toby.
Pleasure. Thanks for having me back, Eddie.
Great to have you. And I thought we'd start with mantle cell lymphoma, one of your favorite topics, and perhaps to start with the BOVen trial. Now, to give some context for listeners, TP53 mutated mantle cell lymphoma has perhaps the worst outcomes amongst mantle cell lymphoma, particularly pronounced in the Nordic 2 and Nordic 3 trials, and even worse than just 17p deleted or TP53 deleted. And so this trial took 25 patients with TP53 mutated. I think the first trial dedicated to TP53 mutated mantle cell, and combined Zanubrutinib with Venetoclax and Obinutuzumab. What did you make of the results of the BOVen trial, Toby?
Yeah, thanks, Eddie. So, yeah, as you say, the sort of first study we've seen in this particularly high-risk population. So this represents about 10 to 15% of mantle cell lymphoma. You alluded to those results from the pooled Nordic analysis, the median progression-free survival under a year with standard intensive immunochemotherapy, including an autologous transplant consolidation, and the median overall survival in these kind of patients, are potentially under 2 years. Although, of course, that is based on a fairly small patient number, it still sort of suggests that these patients do really badly. The BOVen study was looking at a novel triplet, so Zanubrutinib, a second-generation BTK inhibitor, Venetoclax, a BCL2 inhibitor, and Obinutuzumab, second-generation type 2 glycoengineered CD20 antibody. So a triplet that's been studied in chronic lymphocytic leukemia or variants of this triplet, looking at different BTK, BCL2 inhibitors, have been studied in a range of malignancies, most commonly CLL. But this is the first time we've seen this triplet in the frontline setting in mantle cell lymphoma. So looking at non-chemotherapy based treatment in this setting, and the CR rates really high, nearly 90%. The undetectable MRD rates are really high, and one of the nice things about this study is actually there were some MRD guided stopping rules in the clinical trial, which is really nice to see as well. Now, we saw 2-year progression-free survival data presented, and the 2-year PFS was up at over 70%. Obviously, pretty wide confidence intervals given the size of the study, but even given that, compared to what we have historically, this does look to be an advancement in our potential treatment options and treatment approach, and certainly really speaks to the future of moving these highly effective agents further forward in our treatment algorithms, and particularly those with potentially very high-risk disease. So is this a new standard of care now? Well, of course, that depends on all sorts of things, doesn't it? Sort of access primarily. I suppose if I could give it tomorrow to a patient outside of a clinical trial, I would. Now, some places around the world can do that, other places can't. If I could, I would. Absolutely. I mean, I think these results were real standout results from ASH, and a very exciting study from what was basically 2 very large US centers working collaboratively. So I think the study's going to be doubled in number. There's going to be up to 50 patients in the trial. So that will give a nicer sample size, give us a bit more clarity and more understanding about P53. But yeah, a fantastic academic study for sure.
And how do you think about, in such a high-risk group, we're not probably going to get a randomized trial.
No.
So, is that because of the difference with the historical controls, the magnitude of difference that is enough to provide you confidence, or how do you think about that kind of?
Yeah, I think so. I mean, absolutely. Of course, you're extrapolating basically small subsets from historical phase 2 studies with frontline phase 2 selected patients. We didn't have data on time from diagnosis to treatment. We didn't have the screening logs, so we don't know whether some of the sort of super high risk TP53 patients maybe didn't make it onto study, sort of somewhat akin to maybe the historical information we had from double hits, where we thought everybody was awful because that was the group they were tested in. We don't know whether the same sort of rules might apply to TP53. So I think TP53 mutations in Mantle, broadly speaking, need studying in a lot more detail in much broader patient populations to understand the heterogeneity within those. But all those things put to one side, I mean, you can't argue with sort of no patients alive at sort of 2 years versus 73 or something like that. So, I think it's I think it's a step in the right direction, and it's a very hard group to do an isolated randomized clinical trial in. I don't think we'll see that. I think what we'll see in the future probably is detailed subsets from large randomized studies using potentially triplet non-chemotherapy based approaches, perhaps not with this combination, but with similar type combinations in the future. And it'll probably just be, there'll be approval based on a triplet in all patients, and we'll just know that the TP53 patients will almost certainly be the ones to benefit the most.
And I didn't want to let you get away with that hard question. So in this nice hypothetical world where you can access this therapy, would you be happy stopping with the MRD guided approach without consolidation with any kind of transplant or CAR T, or how would you be thinking about it in that hypothetical world?
Yeah, so I mean, I suppose the study was MRD driven because it could be. There was access to the technology. This was a small number of centers, highly sort of organized large academic centers in the US. Extrapolating that more broadly, of course, is more difficult. I wouldn't say the story on MRD and Mantle is by any means sorted. So I think that we need to understand which technique is most well validated, most applicable, most available, and most cost effective. And I think all of those things need to really be understood first before we think about MRD on a sort of large scale. I wouldn't say I have a sort of validated technique that's available for myself in routine clinical practice in the UK. And so I would probably treat, what would I do? I'd give fixed duration, BCL2 and CD20. I'll probably continue the BTK to progression. That's probably what I'd do if I had a patient tomorrow and you said, Toby, pick and mix, choose those 3 agents. How would you treat patients? But that's not quite what the study did. But they had the ability to stop therapy based on detailed data.
I like that. Pick and mix. I might use that going forward. Raj, I think you had a question.
That's hematology these days, isn't it? I mean, a little bit.
Yeah, granted, this was a small number of patients, but did you see any significant toxicity signal or any fatal toxicity with this triplet regimen?
Yeah, that's a good question. I mean, as I said, these are pretty highly selected patients given in a clinical trial setting where investigators are really quite experienced at using the combination, including using the BCL2. But the BCL2 is the main issue here just because of the ramp up phase. But you debulk with the BTK and the CD20. So you've got nice debulking strategies before going into that. The other thing is that BOVen regime has been used in CLL as well in that center or in those centers. So they have experience from a CLL trial of the triplet. But I'd say generally speaking, there's increasing experience of these kind of agents in combination. So I don't think there was a particular issue around toxicity. I mean, neutropenia is the main issue with the triplet and infection, but nothing kind of concerning outside those 2 pretty common toxicities.
I think next we'll move on to the SYMPATICO trial, the long-awaited SYMPATICO trial presented in the late-breaking abstract session, which was of 267 patients with relapsed and refractory mantle cell lymphoma, comparing Ibrutinib plus Venetoclax versus Ibrutinib plus placebo in a randomized fashion. And we saw that the median progression-free survival was 31.9 months in comparison to 22 months, so about 10 months. Improvement with a hazard ratio of 0.65, and an increase in the CR rate from 32% to 54%, which is not unexpected given we're adding a BCL2 inhibitor to a BTK. So yeah, what did you think of those results? And we'll sort of dive in more detail. But first, what did you think of them?
No, thank you. Well, I suppose the study met its primary endpoint. So, we saw an advantage to adding the BCL2 inhibitor. I think I looked at those progression-free survival curves and I was I think my first gut reaction was a little bit disappointed because we know that doublet is so effective in CLL. We've seen data in a small number of patients in the AIM study and then in the OASIS-2 study, the OASIS-1 study of it in relapse and in the frontline setting. And it looks really potent, very good in high-risk disease, very active in TP53 mutated disease. So I sort of had really quite high hopes. And, and there is a progression-free survival advantage, I think, no doubt about that, and that looks very clear, but it's not enormous. It's not sort of game-changing on a sort of massive scale, I wouldn't say. I think there's a bit of nuance here in terms of interpreting this. I think we need to understand which, in a bit more detail, actually. I don't think we have all the detail around sort of which patients might benefit in terms of the toxicity, efficacy, sort of risk ratio that we're used to dealing with the whole time in our clinical practice. It's which patients are sort of fit enough, will tolerate the combination well, and will get the most benefit from that. But I suspect it will be approved based on this data. I mean, it's a positive, big randomized international trial. We don't see loads of those in relapsed mantle, and so we should sort of celebrate that. But I think I want to know a little bit more about who I can give this to safely, and I want to know, again, perhaps a little bit more about who might benefit from it. As I actually asked a question in the late breaking abstract, so, we know a bit about that doublet in the frontline setting in CLL, big difference in toxicity between the sort of GLOW population and the CAPTIVATE population. I sort of want to understand a bit more about that group, or those sort of age groups, comorbidity groups, etc., in relapsed mantle, to get a feel for actually who should get BTK monotherapy, who might get a doublet safely. So I think there's still some open questions here. We haven't seen a sort of parallel manuscript, which we sometimes see in these big randomized studies at ASH. So we'll have to wait for that, and hopefully the reviewers will scrutinize it carefully so we get as much detail as possible. But yeah, I think for potentially younger, fitter patients, particularly also those with high risk features, I suspect this doublet will have a role. I think it shows BCL2 BTK combinations are highly effective in Mantle and do increase the depth of response. And actually, it maybe in the long term, actually, that might have more implications to the frontline setting than it will in relapsed disease. And of course, we've got this open question around Ibrutinib access in some parts of the globe. Obviously, not in Europe at the moment, where Ibrutinib is the only BTK we use. But obviously, in the US, there's been quite a lot of change recently in terms of what's approved. And this is, the Ibrutinib is your control arm. So there are some people who believe that, for example, Zanubrutinib is a more effective BTK, and how would that look against this doublet? Difficult to be sure. We've seen advantage against it and against Ibrutinib in CLL. Would this be the same? Who knows? We'll never know. But yeah, to my mind, a positive study. Hopefully, it will gain approval. The question is who you should give it to.
So you mentioned the second-gen BTKs. The AEs in this study, there was a bit more diarrhea, a bit more neutropenia, and anemia and thrombocytopenia, and a bit more nausea. Do you think if we were substituting in a second-gen BTK in that combination, I'm sure those trials will eventually read out, but in the meantime, do you think those AEs, they're obviously not necessarily the AEs that we typically look at first and second-gen BTKs and say, oh, look, it's way better in the second-gen setting. So do you think that those AEs are kind of going to be pretty similar if you're substituting? And I know we're in well off-piece territory here, but that's sort of partly due to the regulatory context you referred to in the US, as is why I'm asking that question.
Yeah, it's a good question. I mean, I think potentially a little less GI toxicity. And by the way, 65% sort of diarrhea and nearly 10% grade 3 diarrhea is substantial GI toxicity. I mean, let's sort of underplay that. That's, a lot of patients getting a lot of GI toxicity with that combination. Whether that would be genuinely better with the second-gen BTK inhibitors, perhaps. Diarrhea is a little bit less in the sort of CLL studies of Ibrutinib plus versus Acala. It's fairly similar, maybe a little bit less in the head-to-heads with Zanu. Cytopenias, particularly with Zanu, actually about the same. Most of the benefit with Acala or Zanu is obviously cardiac, and then with Acala Ibrutinib, there's benefit in terms of things like myalgia, arthralgia, hypertension as well. So yeah, the cytopenia is perhaps less so. So I don't know. I mean, it's a slightly moot point, and we won't see, I don't think, the studies of the second-gen BTK inhibitors in relapsed disease. I think what we'll see, and what we are seeing moving forward, is for example, Acala, Retux, Ven in the frontline setting. I suspect, although this hasn't been confirmed, we'll see Zanubrutinib plus Clax as a new name for their BCL for Zanu's for BeiGene's BCL2 plus Retux. I'm sure we'll see that triplet probably in a pivotal study of some sort in the frontline setting. I don't think we've seen details of that as yet, but I suspect we'll see that some point in the future. So BCL2s very much have a role, but I think toxicity is less generally in the frontline setting, obviously for a variety of reasons, younger patients, chemotherapy naive, etc., less marrow involvement. So I suspect toxicity in sort of cytopenias, etc., will be less, but yeah, we'll have to wait and see.
No, totally. I mean, I mostly ask because if you're, not everyone, I think, in the US has yet adopted the triangle regimen, which still leaves kind of BCL2s in the second line setting. And so to me, the kind of relevant clinical question that SYMPATICO raises right now is, if you're using a BTK in the second line setting, should you be adding Venetoclax in the kind of pick and mix context, which is why I asked the question.
Yeah, I mean, potentially, I suppose. Venetoclax has never been approved, has it? And it's never undergone a pivotal trial in a phase 2 pivotal study in mantle cell lymphoma. So that's certainly the sort of, I guess, the pure question to ask. Is 2 better than 1 given sequentially after the next? The reality is, though, of course, Ven has never been routinely available broadly for mantle cell lymphoma, unlike say Ibrutinib. So it's quite a hard sort of thing to model outside of a clinical trial at a later point. But of course, it'd be very interesting to know what therapies were given subsequently. Was much BCL2 inhibitor given following the Ibrutinib? The data that's in the literature, including a UK study that I put together a few years ago, shows that actually the benefit's fairly transient for Venetoclax post-covalent BTK, and probably it's better off giving in combination much earlier on. But yeah, I think there's obviously a bit of off-label use in the US, as we know, but there's very little actually outside of that setting.
Yes, I guess the proof will be in the pudding, depending on what the rates of crossover are when the SYMPATICO trial is published.
Yeah, we'll look out for that. I'm sure Twitter will look out for that.
Absolutely, as they should.
Yeah.
So I wanted to move to CLL, and I think the headline study there is the FLAIR trial. Now, of course, you're biased because you're a co-author, but interested in your insights nonetheless. And FLAIR is obviously a very large UK multicenter adaptive trial in CLL, and this readout was comparing FCR, so chemoimmunotherapy, compared with MRD-guided duration of Ibrutinib plus Venetoclax in patients with untreated CLL who required therapy. And the unsurprising bit is the hazard ratio for PFS was 0.13 and for overall survival 0.31. So clearly Ibrutinib plus Venetoclax beat FCR, but anyone, I think, could have bet on that result. I think the more interesting stuff regards the MRD and MRD stopping and how that compares with fixed duration therapy, which we've obviously seen in multiple other CLL trials. So first I wanted to ask you about the MRD. How is the MRD performed, to what depth, bone marrow, blood, and how is that relevant in the CLL context?
Yeah, sure. Thank you. So MRD was performed both in peripheral blood and bone marrow, although, of course, there were less sequential bone marrow samples throughout the study, and it's hard to rely on bone marrow results to be the result that guides your stopping rules, because clearly it's much more unreliable to always get bone marrow samples. All you need is a patient to say no thank you, and you lose your sort of key endpoint for decision making. So peripheral blood is the sort of decision making point, and as you say, MRD guided, so patients essentially had twice as much therapy as the time it took them to become MRD negative. So it's effectively personalized therapy based on the sensitivity of one's disease to that very effective doublet, as you've already described. And no one was, as you say, surprised by the fact that it beat FCR. I think some people might be slightly surprised. Just to push back on your statement a little bit about the magnitude of benefit at the time point. So this is a 3-year data, has a ratio of 0.13, very few progression events in the I+V arm. And remember, this is therapy not in a highly selective group of patients. The FLAIR study is delivered across sort of 70 sites across the UK, right across the UK, across a range of sort of socioeconomic groups, etc. And to get an overall survival readout at that time point as well was well, to some degree a little surprising, but actually speaks to the sort of benefit of the experimental arm. But MRD was tested peripheral blood and marrow, so some correlative science that was then subsequently sort of shown in the next abstract. But in terms of the decision making, it was peripheral blood. And up until now, we haven't seen results in that experimental arm as good in CLL. So progression-free survival at 3 years over 90, I think over 95%. And you know, if you sort of do the thing you're not supposed to do, which is cross-compare across I plus V from the CAPTIVATE study, it does look potentially better. Of course, what you really need is an MRD-guided trial versus fixturation to really hone down on the benefit of the MRD-guided approach. But until we get to that point, you know, we can hypothesize that this perhaps looks better, but you can't know that with absolute certainty. What it does do is it provides personalized therapy for patients. So people who are highly sensitive to the disease can stop therapy early and minimize toxicity, and the reverse also being true. So it certainly makes scientific sense and has a great rationale behind it. Of course, the major question here is what on earth do people do with those results? How do people nationalize MRD testing? Are we at a point where we look at those results and say, okay, right, that needs to happen now? Or is this a point in time where people need to start developing clinical trial protocols where MRD guided therapy is one of the arms of treatment? Because up until this big randomized study, we've seen sort of some neat data from sort of smallish phase 2 studies. For example, Matt Davis put together a very nice study of, I think, Ven, Acala, Obin, and did something similar, but it's a kind of descriptive phase 2 study. Yeah, so it sort of raises more questions than it does actually provide answers, which is quite interesting. And the other thing that will be really interesting to see what industry do with this. So, you know, will the big companies with a lot of money and the BCL2, BTK inhibitors, you know, believe that going beyond fixturation, which of course, you know, we all know is just widely applicable and easy to deliver. And, you know, when you're thinking of sort of market share and deliverability, it's so different to this strategy. Now, will they sort of buy into a strategy where MRD testing is part of the package of a therapeutic combination, or will they just say, well, it's sort of nice, but we're going to stick with our fixturation, thanks very much, because you can give it in, well, pretty much any country in the world, basically. I know what I think, but science and pragmatism may not be entirely the same, entirely aligned, but that's the challenge I think that this study really brings to light, or at least sort of brings up a new debate in frontline CLL, actually.
Yeah, I mean, one of the most interesting things for me to see was that at 3 years, 58% of the I plus V group had stopped. 4 years, it was 72%, and 5 years, it was 78%. And that's from a very helpful table in the supplement. Thank you. And so, you know, to me, there's obviously a group there that are, not obviously, but perhaps benefiting from that ongoing therapy. And as you say, I think one of the really interesting things is to also consider the question of, you know, are we curing? And I want to ask you this question. Do you think, what's your hunch? Are we curing people with this kind of MRD guided approach to doublets in CLL?
Yeah, it's a good question.
I won't hold you.
I'm going to stick my neck out and say if we're curing patients with FCR, which I think people believe we are, and I think if we're curing patients with Veno, which I think probably we are, then yes. I suspect we're curing some patients, low-risk patients, yes, but probably some patients with I plus V with shorter duration therapy. But I think we have a higher chance of potentially curing more patients. Time will tell. But I think, you know, I'm fairly convinced that, for example, Veno will cure patients. The MRD negativity rates are clearly higher with Veno and I plus V than immunochemotherapy. And actually, the studies that we'll come on to, the CAPTIVATE study, etc., and the GLOW study as well, show, particularly in the mutated disease patients, you know, 4-5 year follow-up progression-free survivals of sort of over 80%. I think a proportion of those patients will be cured. Yes, I don't think we can kind of fully identify them yet. I mean, they'll be in the mutated group, almost undoubtedly, but yeah, I think we probably will. Whether we'll cure more with MRD-driven therapy than fixturation, I think you need an MRD-guided study versus a fixturation study to actually
really know.
Yeah.
And you did remind me of another question I wanted to ask you, which is, I think there was an Ibrutinib or multiple arms of FLAIR. So
Yep.
kind of when and or what, how does the decision in an adaptive trial go into deciding when you compare two different arms? Are we likely to see a comparison of the I plus V versus the I arms of
Yes.
the FLAIR study?
Yes, we should do. But it's yeah, I mean, the statistics of an adaptive design of 1,600 patients are complex, and I, for one, don't fully understand them. But yes, we'll need adequate numbers of events, but we can compare ibrutinib-based therapy versus I plus V. We have done in the sort of MRD. There was an MRD abstract previously presented that sort of was of some interest, but of course there were massively higher MRD negativity rates with I plus V. No surprise there. But yes, we'll see. We should see a readout of I versus I plus V. The whole premise of the study is you're still, although when you add arms, you still will ensure adequate stratification between the arms and the randomizations as the trial goes along. So yes, we should see that in time, fairly soon, hopefully. I mean, not many people are now using ibrutinib frontline if they've got access to second-gen BTK inhibitors, but I still think sort of proof of principle I versus I plus V will be a really important study endpoint. And also we'll see that from the CLL17 study as well. So we'll have more than one data set to look at that question.
Yeah, I had a quick follow-up question on the MRD depth that you use in CLL. For example, in myeloma, we struggle with flow cytometry because there is a lot of variability between institutions, and we prefer adaptive NGS MRD because it's standardized. So in CLL, is the flow standardized? And what depth do you typically use to call MRD negative currently?
Yeah, so I mean, there's obviously sort of studies ongoing comparing different techniques, and actually there's a very interesting readout from the CLL13 study where actually NGS looked to be a little bit more sensitive in terms of sort of predicting for improved disease control over time. But routinely, flow-based technology has been very well validated, and the technique has been well honed over many years by the Leeds team in the UK. So flow is what the study used, basically, as a primary readout. Bearing in mind, by the way, this study obviously was sort of designed the best part of 10 years ago, or started the discussions around 10 years ago, and has been, the MRD technique has been sort of honed over that time by Andy Ralstrom. You basically need to clone Andy Ralstrom and put him in every country in the world, set up a lab, and then you'd be fine. You could do MRD driven studies, but sadly we're not allowed to do that, are we?
As you say, the science.
In all seriousness, I mean, it actually takes clearly quite a skillful lab to be able to safely validate that test, to be able to perform it on a national scale, and reliably perform the test so that you can response adapt based on it.
Yeah, absolutely. That was a really insightful. Thanks, Toby. I want to also pick on the CAPTIVATE trial briefly, which obviously CAPTIVATE had an arm where patients received fixed duration Ibrutinib plus Venetoclax, and an arm where they received MRD guided treatment. But I wanted to focus particularly on the group that got Ibrutinib retreatment, because I think that, we talk a lot about Venetoclax retreatment, but the advent of fixed duration therapy also suggests that Ibrutinib retreatment might be possible. And so the first interesting point from the study was that the estimated 4.5-year rate of freedom from next treatment was 82%, which is cool to give some patients some time off therapy. And of the patients who had progression, 28 of them reinitiated with just Ibrutinib, and 6 with Ibrutinib plus Venetoclax, with an overall response rate in both those groups over 80%, and a median time on retreatment of 14 to 17 months. So I really want to get your thoughts on how you would think about endpoints in CLL trials as a result of this. Should we be thinking about the total time of benefit from the drugs that the patient has access to, be that Veno or IV or whatever combination, or how would you think about endpoints in the context of many patients who have received fixed duration treatment being able to receive retreatment?
Yeah, I think it's a really good question. And actually, sometimes I think fixed duration therapies get a bit of a raw deal there, because, the PFS events don't biologically basically mean the same thing. And maybe one of the sort of classic subgroups that actually really suffers here is, or not suffers, but the classic subgroup we talk about here is P53, where pretty much every expert around the globe recommends continuous BTK inhibitor. But of course, all those progression events in those patients are all disease resistance, whereas they're clearly not in Veno-treated patients or I+V treated patients. And, this study demonstrates nicely that you can re-establish disease control with BTK-based therapy. And we've also got data from Murano. There's ongoing studies in the frontline setting, and also some real-world data suggests that Venetoclax retreatment's an effective strategy. So, yeah, should we be using PFS2 with second-line therapy continuous rather than PFS1? Maybe. It's a bit more difficult to model. We may start to see that in the future where more and more therapies become fixed duration. And this may not, of course, just to apply to CLL. You might see it more with, say, bispecific antibodies or more combinations of other novel approaches that can drive deep responses where retreatment's an option. I certainly think that's where CLL is heading, and some other diseases as well. Yeah, I mean, I guess it becomes a question of what regulators accept when it comes to at least, pivotal registrational studies, and also what the field accepts more broadly. There hasn't been a huge push for it in CLL as yet, but that might change. That answer slightly sits on the fence, I know, but that's partly because I think, we've still got a very much an evolving field. I mean, we're only just starting to see retreatment BTK data, for example. It's only really in the last kind of sort of 6 months we're starting to see that you can retreat people with. I don't think people are surprised, but it's still fairly new. So maybe is the answer to that. Yeah, I'm not sure companies will like it, obviously, because of the timelines involved. They're always, as you know, wanting to push for sort of earlier and earlier readouts of, surrogate markers and so forth. And actually, we've seen co-primary endpoints with MRD, obviously from, for example, the CLL13 study, a co-primary endpoint of 15-month MRD, which was, acceptable. So I don't know, it slightly goes against sort of at least timelines. It might be biologically and sort of clinically a sort of practical thing, but whether that really makes its way through to what happens with the FDA and so forth, I'm not so sure.
I mean, I think it's important clinically for people to know that in fixed duration settings that retreatments can be worthwhile trying. And I think it's important, as you say, when comparing different trials and different strategies, to remember what a PFS means in this context versus what it means in that context.
Yeah, totally.
Yeah.
I mean, I think we'll see it when the results potentially benefit the company. So, for example, there is obviously a reason why we're seeing Ibrutinib retreatment in this study, right? This study follow-up is deliberately long to capture these events because this is obviously a J&J sponsored study. We're not seeing post-protocol care broadly captured in as detailed a way as this. So, maybe we'll see, for example, I don't know, when we see Mosun fixed duration in FL in the frontline setting, they'd probably be wise to stick in a Mosun retreatment arm and collect data and provide PFS2 with that strategy, for example, in the future. I can sort of see an era going in that way, or even, if we see BCL2 BTK, for example, the BeiGene combination, if we see that in the frontline setting, they might be wise to stick in the protocol retreatment with the doublet and provide PFS2 there, for example, with long-term follow-up. I can sort of see that happening, but it will be, at least for now, from registrational studies like this, would very much be on the, I think, company's own terms.
Yeah, I think that's spot on. Let's jump to Hodgkin lymphoma briefly to talk about the elderly or unfit patients over the age of 60 years reported at ASH. So SWOG 1826, as anyone who's listened to our great episode with Nancy Bartlett will know, is a large randomized trial of nivolumab AVD versus brentuximab vedotin AVD for untreated Hodgkin lymphoma, which was initially presented at ASCO this year and showed an improved PFS and improved toxicity, and dare I say also improved cost, for nivolumab AVD versus brentuximab vedotin AVD. And the results for patients over the age of 60 years presented at ASH were, I guess, even more impressive, with a 1-year PFS of 93% compared to 64%, a 1-year overall survival of 95 versus 83% with a p-value of 0.09, so not quite significant, and fewer AEs in terms of neuropathy, diarrhea, and nausea, and febrile neutropenia in nivolumab AVD. So the magic question is, 1-year data enough to shift your practice, Toby?
Yeah, it's a great question. So not normally. I mean, obviously, Hodgkin results, you normally need sort of long-term follow-up for for example, OS and secondary events, and the BVAB, the Echelon-1 study took a long time, for example, to show an OS benefit. So normally you need long-term follow-up. But I think here there's a substantial difference in terms of toxicity profile, in terms of non-relapse mortality. I think 4 versus something like 10%, and in the 60s to 70s, the TRM was 14%, I think, with BVAVD. I don't think BVABD given in combination as it is in this study is probably the best way to give it in older patients. I think probably the sequential approach from Andy Evans' JCO paper is probably a neater way to give it. So giving BV and then ABVD and then BV, I think is less toxic. But I think you do get substantial toxicity with BVABD, and I think it obviously speaks to, this study obviously speaks to that. I think the improved efficacy is probably a combination of factors. Nivo clearly in the elderly doesn't induce too much sort of immune-related tox. There's probably some immune senescence that actually sort of plays into actually that benefit. It's very well tolerated, but also clearly providing the disease control that's adequate. So with little in the way of sort of concerning toxicity. So yes, is a sort of shorter answer to that question. Again, it's an access thing. I mean, we in the UK, we give response adapted therapy in, say, those who are 60 to 70 and still use a RATHL based approach in many instances. And actually a lot of places don't have access to BVAVD anyway, but in those places that do, I think they shift overnight, actually. And that's quite an unusual thing to say with a 1-year readout. But you've got, it's obviously a modest sized, I can't remember actually if it was a post hoc sort of unplanned or pre-planned analysis, but nonetheless, it's that the magnitude of difference is substantial, and there's nearly a statistically significant OS benefit at 1 year, which I suspect will probably become more significant over time. So yeah, I would change my practice based on this.
I think it really,
if I use BVAVD, yeah.
No, I mean, well, I think this is the other challenge because Australia's the same, that where you sort of never really had BVAVD in the frontline setting, will those places decide to fund Nivo AVD either for all comers or in the elderly in the frontline setting? I think will be interesting to see.
Yeah.
Given that sort of all the benefits line up in terms of different things, but where you're comparing the sort of almost leapfrogging of BVAVD in many places where it hasn't been funded.
Yeah. Absolutely. I mean, we would use sort of generally ABVD ×2 and then pretty much always drop the bleo after 2 cycles, sort of regardless of the PET, based on some of the data in elderly patients around bleo toxicity and infective toxicity in older patients. So I'd be amazed if Nivo AVD isn't better than that. So yeah, I'd use it tomorrow if I could, based on these results, even without availability of that control arm, because I think those results really sort of speak for themselves. So yeah, it's an access issue as much as anything.
And a big year for Hodgkin. Let's jump to DLBCL. I thought the SMART STOP study from Jason Weston and MD Anderson was very provocative. So in this study, and correct me if I get any of the trial design stuff wrong, because it's quite complex, but
it is complicated, yes.
From my reading of the slides, the regimen that was being tested is called ULTRA, which is lenalidomide, tafasitamab, rituximab, and acalabrutinib. And you got 4 cycles, a small but very provocative, as I said, trial. We were 30-something patients where you got 4 cycles of ULTRA. And then if you're in a CR after 4 cycles, you get 2 cycles of CHOP plus 6 cycles of ULTRA. Whereas if you are in a PR or less, then you get 6 cycles of CHOP plus 6 cycles of ULTRA. And impressively, 19 patients, 63%, had a CR, and so those 19 patients only received 2 cycles of CHOP. And of course, the impressive part is that the PFS and overall survival curves are completely flat, like many of those early nivolumab curves in Hodgkin. And there was also undetectable ctDNA in a third of patients getting the ULTRA regimen. So I would love to hear thoughts both on this trial specifically, but also generally on kind of how we go about beating chemotherapy in DLBCL.
Yeah, thanks, Eddie. Yeah, it's provocative. It's certainly interesting. It's brave. So credit to Jason and his team for thinking outside the box here. So yeah, absolutely. So this comes off the back of a study called, I think, the Smart Start study, which was where a sort of similar type design where lenalidomide, Ibrutinib and rituximab was used in combination and sort of debulked patients and enabled a reduction in chemotherapy number. I suppose the point here is you're using sort of theoretically synergistic non-chemotherapy based approaches to induce deep remissions and limit the number of cycles of chemotherapy. And actually they, up to this point, at least prove that you can do that in at least two-thirds of patients. You could argue the other third of patients are getting substantially more therapy than they would have otherwise had, but you could also argue that in the long term, if those patients don't progress, then maybe that's a benefit to them. So yes, I mean, the regime is sort of designed to target the non-germinal center group, but there were both germinal center and non-germinal center patients in the study by the sort of Hans algorithm. But they met their primary endpoint. They aim to show a benefit above a CR rate of 36%, which was what the Smart Start study showed, and it was 63%, as you mentioned here. And those patients actually only then had 2 cycles of CHOP. But this is multiple drug companies, multiple agents, multiple companies with different interests and different priorities in terms of the long term. This is not a regime that most places in the globe could put together at short notice or ever. It's an untested combination in large numbers of patients, and the follow-up is, I think, 9 months. So there are some caveats here, and it needs clearly a large randomized clinical trial. But you also need to provide an experimental arm which is applicable beyond, sites like the MD Anderson in reality, because I'm interested in this study because of the science, not because of the applicability, actually, because I don't see a combination like that ever making it to my clinic. And I suppose that's the challenge, isn't it? You have all these agents, you have the ability to run a smallish study like this, but how does that ultimately result in practice change? So, yeah, it's tricky. I would also say that if we look over the last, say, if you look over the last 20 years in DLBCL, what therapies have genuinely changed practice? Well, they've all been actually sort of ABC, GCB, sort of agnostic therapies, haven't they? Rituximab, glofitamab, even CAR T therapy, these Obinutuzumab, these therapies that actually
we can debate whether polatuzumab is ABC,
Sure.
GCB, agnostic.
Oh, yes.
Yes.
Well, yes. Okay. Well, it wasn't initially designed. Well, it wasn't initially designed to be sort of targeting ABC or GCB, I would argue. But yeah, I mean, I suppose the idea, or at least the principle initially, was that these therapies that have been successful actually have been successful primarily, at least in a designed fashion, to be agnostic to those subtypes. And they've been enabled to be given as monotherapy alongside chemotherapy or whatever, in a sort of way that actually enables the broader applicability sort of beyond small studies in massive academic centers in the US. So that's where I see the challenge here. I would welcome a randomized trial. My question would be, what happens if the study is positive? Because you don't want a situation where you've got an experimental arm that can only be used sort of off-label in the US, actually. That's what you want to avoid, I think. But maybe that's because I'm a sort of jealous Brit. I don't know. Quite fun to use the combination, I'm sure. But I mean, I think the reality is for most places in the globe, something like that is inaccessible.
Totally. I mean, I think it's sort of interesting to me to see how the bispecific companies are going about this question as well, where many of them are just kind of adding it to or replacing the R in and CHOP. And the tricky question for me, I think, over the next 10 or 20 years in DLBCL is if 60% of patients are cured by R-CHOP or perhaps more, how do we have trials that help those 35% without necessarily giving more toxicity or changing things up or disadvantaging the patients who were going to be cured anyway? And I think that speaks to a lot of the trial design questions. And so from that point of view, I think this is a provocative kind of going for the home run, high risk, high reward, perhaps strategy.
Yeah, issue that I have no issue with cycle of chemotherapy de-escalation, because I think that's the way forward, because then the magnitude of benefit beyond R-CHOP or polar R-CHOP or whatever you choose or your control arm, the magnitude of benefit doesn't have to be as large because your tox profile will probably be improved. So reducing cycles of chemotherapy, that principle, and I like there are many things I like about this study. The issue and the challenge that exists here actually is a practical one around access to novel agents in this as well. The 3 novel agents, I suppose. Clearly, Len will become less expensive in time, but Tafa and Acala, 2 completely different companies, different priorities, different actually disease focus areas, etc. What do you do with that? That's the issue. So yeah, chemotherapy de-escalation, absolutely. And actually, I'd like to see, for example, studies where bispecific antibodies do that. You know, you go in early with maybe CHOP and bispecifics or whatever, and actually you just de-escalate all patients or de-escalate the CRs. You could do that, and then actually give fixed duration bispecific with chemotherapy or something like that. You can see actually that's not just sort of moving forward with the status quo of adding to R-CHOP, because you need to be able to, unless you provide a massive magnitude of PFS benefit, you need to be able to reduce or limit toxicity, and cycles of chemotherapy sort of has to be one of those major ways forward. Yeah, it's an interesting study for sure.
And I think on the topic of bispecifics, we should talk about the Mosen-Polar data in DLBCL, which was 108 patients over the age of 80 years or over 65 and ineligible for chemotherapy based on comprehensive geriatric review. And they showed an overall response rate of 64% at the end of therapy, with best overall response of 80%, with 50% PFS at 1 year, of course, early data. How do these kind of data factor into your thinking about patients, elderly patients or unfit patients with DLBCL?
Yeah, so I think, again, quite provocative data, quite a large series in the frontline setting of Mosen Polar. So you've got a slightly interesting group of patients here that are considered fit for a clinical trial and will enroll into a prospective study. That patients will come up for infusions, etc., to the treatment unit. They're not all elderly. They generally have a reasonably good ECOG, but for some reason they are considered unsuitable for chemotherapy. Although in the questions of the presentation of the study, there was a sort of an admission that actually these were probably sort of our mini CHOP fit patients. So in light of that, I'm not convinced this is sort of a massive step forward at the moment. I think these results are actually pretty equivalent to what you'd see with our mini CHOP in this kind of group of patients, if I'm honest. And so we have to see randomized data here. And it is interesting that I think these are our mini CHOP fit patients, basically. It's interesting that investigators were prepared in the frontline setting where we know we cure half of patients. I appreciate we're not curing 80% of elderly patients, right? But investigators are kind of happy to enroll in a sort of completely unknown combination in terms of actually toxicity and efficacy in a group of patients who were potentially curable in the frontline setting. So I'd be interested to see what we see with the PFS curve. Actually, it's sort of a couple of years, because Mosen monotherapy doesn't cure as many patients as our mini CHOP. We've seen a sort of a study previously in a similar type group of patients. And yeah, I think we actually have a little way to go in the elderly in terms of knowing maybe what that balance is around chemotherapy use versus novel agent combinations, really. So yeah, interesting. I think quite provocative as well, actually.
Yeah, I mean, I think it's all about balancing efficacy and toxicity. And as you say, selection for studies it's so hard to know. And I think the same is true of Pilot and Alicante, which look at CAR-T and the elderly, is, unless you randomize, is the clinician really sure that this patient is fit or isn't fit? It's such a kind of end of the bed and such a clinician discretion thing and it's, there's no statistics you can do once a patient's enrolled or not enrolled in a trial to correct for that kind of investigator decision. So I totally hear and agree with you with 100 patients here getting a combo where these are patients that we know at least some of them could have been cured perhaps by our mini-CHOP or our CHOP. And so, yeah, the only way really around that is randomization, as you say.
Yeah, absolutely. Absolutely. I mean, the median age of 81 in the study overall, most patients had an ECOG of 0 to 1. I would just wager most of those patients are fit for our mini-CHOP. So I'm sort of just intrigued that in some respects, people had no problems in enrolling into the study. I mean, I can see how you'd sell it to a patient, don't get me wrong, but
you can still get the mini-CHOP in many cases. I suspect, you have it ready and waiting.
True, absolutely. I guess you don't know sort of how those patients would fare, but I suppose if you had a sort of stable disease after 3 cycles or whatever, you just switch, don't you? But yeah, it's an interesting sort of concept, and I think we're still trying to work out which combinations a bispecific should be in the frontline setting, particularly in older patients. And should it be Glofit? Should it be, I suppose, from a Roche point of view, should it be Glofit or Mosun? Again, that's a trade-off of efficacy and potential toxicity.
Totally. Well, I think that brings us pretty close to the hour, and we've covered quite a lot of distance across different lymphoma subtypes. So thank you very much for joining us again for the ASH Lymphoma Roundup. It was a delight to have you back on, and look forward to seeing you soon.
Pleasure. Thanks for having me. Thanks very much.
Thank you.